going to discuss about adenotonsillectomy. The points to focus are preoperative assessment, indications for tonsillectomy, indications for adenoidectomy, contraindications for the same procedure, preoperative measures to be taken, operative steps to be remembered, post-operative care for the patients, and then the complications which can occur as a result of these two procedures. Preoperative assessment. The family history of coagulation disorders is very important. It's a bleeding surgery, so it is very important. History of easy bruising, which is a first point towards bleeding disorders. Coagulation screening, prothrombin time, partial thromboplastin time, bleeding time, and platelet count. Obstructive sleep apnea, corp movement. So these are all very important for post-operative recovery after anesthesia. So if the patient gives an history, then polysomnography or sleep sonography, X-ray, chest, which is vital, however, ECG and cardiological consultation, an optional thing if the patient complains of obstructive sleep disorders. Screening for sickle cell disease and peripheral smear is done in India as in a routine fashion. Indications for tonsillectomy: chronic or recurrent tonsillitis, peritonsillar abscess, tonsils causing febrile convulsions, cardiac valvular diseases associated with recurrent streptococcal tonsillitis, hypertrophy of the tonsils causing excessive snoring, sleep disturbances, obstructive sleep apnea, cor pulmonale, dysphagia, interference with speech, suspicions of malignancies like asymmetric tonsillar hypertrophy on one side. Coming on to the relative indications: diphtheria carriers, streptococcal carriers, chronic tonsillitis with bad test or halitosis, recurrent sore throat or upper respiratory tract infections, recurrent streptococcal tonsillitis in valvular heart disease, tender cervical adenitis, difficulty in eating, tonsillolithiasis, orofacial or dental abnormalities, failure to thrive, enuresis, obstructive tonsils in infectious mononucleosis. Palatopharyngoplasty for obstructive sleep apnea syndrome, glossopharyngeal neurectomy, or all as a part of other surgeries. So the ninth nerve is severed in bed of the tonsils, removal of styloid process. Indications for adenoidectomy. So indications for adenoidectomy include adenoid hypertrophy, which shows excessive snoring, mouth breathing, OSA, cor pulmonale, failure to thrive, enuresis, and dysphagia, sleep abnormalities, speech abnormalities such as rhinolilia clausa, craniofacial growth abnormalities. Purulent adenoiditis, recurrent sinusitis, middle ear infections, chronic secretory otitis media, chronic recurrent acute otitis media, benign CSOM with recurrent ear discharge, dental malocclusions. The contraindications for the procedures include anemia with an hemoglobin less than 10%, acute respiratory URTI or acute tonsillitis, overt or submucous cleft palate. Conservative adenoidectomy should be done in this submucous cleft palate. Blood dyscrasias, they are an absolute contraindications. And then epidemic of polio, as already discussed. Uncontrolled diabetes mellitus, cardiac diseases, hypertension or asthma. Then the procedure of menses obviously should be postponed. So surgical methods are the guillotine methods, dissection and snare method, electric catheter method, that's named by Bowie and bipolar, also called as bipolar method. Laser method using KTP laser or carbon dioxide laser. Cryosurgery, harmonic scalpel using ultrasound technology. Coablation method where radiofrequency bipolar current. Intracapsular tonsillectomy or tonsillotomy is also done. Powered instrumentation using microdeprivators. Preoperative measures: no food for 8 hours, clear fluid for 3 hours, sedations with midazolam, intravenous ampicillin or amoxiclav, intraoperative dexamethasone in OSA disorders. Anesthesia, general anesthesia is usually preferred with endotracheal intubation position, Rose position, as seen in the diagram in the photograph. Operative steps: so opening the mouth with Boyle-Stevens mouth gag, and then packing that is being done, the boil stage, mother is put, the packing is done, and then the incision is taken with the anterior pillar, and later the dissection is started from the upper pole to the lower pole. Later the lower pole is crushed, cut, and removed. The instruments used are as shown below. Okay, graphene board, stands, Maguiron's plate, Dennis Brown tonsil holding forceps, first artery forceps, second artery forceps, and then suction curates. Post-operative care includes keeping it in the decubitus, left decubitus position, also called as tonsillar position. When the patient comes back from anesthesia, left lateral position. So nil by mouth for 6 hours. Later ice cream, cold ice cream, so that it soothes the throat. Okay, complications can be a primary hemorrhage, reactionary hemorrhage, injury to the teeth, aspiration of foreign bodies, pulmonary edemas, obstructive sleep apnea, and carpulmonary edema of the tongue, nasopharynx, and palate. Delayed complications like secondary hemorrhage are because of the infections, so that has to be taken care with the change in antibiotic. Usually occurs in the second week. Rare complications can occur: peritonsillar abscess, draining forceps. This is the Quincy forceps.